Hi, everyone. Welcome back. And it's nice to welcome and introduce my good friend, Dr. Kevin Tucker. Kevin is Chief of Nephrology at the Brigham Faulkner Renal Division, which is part of the Brigham and Women's Hospital and Mass General Brigham network. Kevin has recently, a couple of years ago, stepped down as program director for the Mass General Brigham Renal Fellowship Program, one of the largest academic fellowship training programs. Kevin is also director of dialysis at the DCI unit at the Faulkner Hospital. Kevin has many other roles. I can't go through all of them, but is faculty director for accreditation for CME at Harvard Medical School, as well as being a very innovative creator of content, including some content that will be posted on our HMS website on race and disparities, as well as on the coronavirus. So Kevin, thank you very much for joining. Kevin is going to talk about dialysis and transplantation. Kevin?
Thank you, Dr. Singh. So good morning. Welcome to everyone. I have no disclosures for this presentation, and I'm happy to talk to you about dialysis and transplantation. I take care of many dialysis patients, so I'm very passionate about this particular topic. So what I want to go through in the course of the next 30 minutes or so is a little bit of the scope of the problem, talk about the demographics of who requires dialysis in the United States. We'll talk about preparing the patient for renal replacement, and then we'll talk a little bit more specifically about hemodialysis, peritoneal dialysis, and transplantation. And then we'll end by talking about dialysis and transplantation in the COVID-19 pandemic. So first, let's talk about what we mean by renal replacement therapy. This is the general nomenclature that is used to designate the forms of therapy that are used to replace the kidneys when the kidneys are no longer adequate to maintain life. And these include hemodialysis, peritoneal dialysis, and transplantation. So first, I'd like to show you a little bit about the trends and the rates of end-stage renal disease in the United States by incidence. And you can see that starting in the 1980s, we had this very sharp increase in the incidence of end-stage renal disease in the United States. However, more recently, since the beginning of this century, we've had somewhat of a flattening off of the incidence rate of end-stage renal disease. And I think there are a couple of explanations for this. The cause for this rapid growth in the 1980s and through the 1990s was that more and more patients were considered eligible for dialysis. When the end-stage renal disease program was created in 1972, diabetic patients were generally not considered candidates for renal replacement. However, in the 1980s, we started to add more and more diabetic patients to the rolls. However, we have done a better job, I think, of treating chronic kidney disease, so we're having fewer patients reach end-stage renal disease, and that probably accounts for some of this flattening off of the rate of the incident rates of end-stage renal disease in the United States. Everyone is talking now about disparities in healthcare, and one of the striking disparities in end-stage renal disease is that minority populations are at much greater risk for end-stage renal disease compared to white populations. So if you look at African-American patients compared to white patients, you can see that there's a much higher prevalence of end-stage renal disease amongst patients of African descent, marked by this line, compared to white patients by this line. But you can see that there are other disparities by race as well, and you can see that Asian patients, Native Hawaiians and Pacific Islanders, and Native American patients are all at greater risk of end-stage renal disease than white patients. And this can be accounted for by social determinants of health, race, racism, poverty, all the usual suspects in terms of social determinants, but also by genetic factors. And that story has been revealed to us more recently, especially in the African-American population, by the discovery of specific genetic alleles in the African-American population that predispose to the development of kidney disease and end-stage renal disease. If we look at how patients receive renal replacement, you can see that in the United States, the largest number of patients are receiving hemodialysis. And peritoneal dialysis accounts for the lowest number of patients who are receiving renal replacement. And then transplantation is somewhere in the middle. So you can see there's a striking disparity in the number of patients who are receiving hemodialysis relative to peritoneal dialysis. This may change because of the American Kidney Health Initiative, which was announced exactly almost a year ago by President Trump and the Department of Health and Human Services. And this American Kidney Health Initiative has a few specific goals. First, it is to reduce the number of Americans developing end-stage renal disease by 25% by 2030, by having 80% of new end-stage renal disease patients in 2025 either receiving dialysis at home or receiving a transplant, and doubling the number of kidneys available for transplantation by 2030. And you can see, based on the numbers that we saw from the last slide, that if we're going to increase the numbers of patients who are receiving both transplantation and home dialysis, that we have our work cut out for us. So let's talk a little bit about the indications for dialysis. The indications for dialysis include acid-base disturbances, electrolyte abnormalities, ingestions, fluid overload, and the syndrome of uremia. The syndrome of uremia is hard to define. We as nephrologists think we know it when we see it, but some of the signs and symptoms may include things like nausea and vomiting, anorexia, dysgeusia or the loss of taste, pruritus, pericarditis, and a general sense of being unwell. So when one is deciding about renal replacement, I think the first decision is whether the patient should receive renal replacement therapy at all. And we'll talk in upcoming slides about conservative management. But if the patient is going to receive renal replacement therapy, the first question is, can the patient receive a preemptive transplant? That is the best option. The patient can be transplanted preemptively. If not, the next decision is about dialysis. And if dialysis, whether the patient will receive home dialysis or in-center dialysis. If the patient chooses in-center dialysis, the decisions are done. But if the patient chooses a home therapy, then there are two options, and that's peritoneal dialysis at home or home hemodialysis. Home hemodialysis is rarely utilized in the United States. Most home dialysis in the United States is done by the peritoneal route. Conservative or non-dialytic therapy may be appropriate in some patients. In patients who are frail and of advanced age who start on dialysis, there really is no increase in survival and no improvement of quality of life. And I'll show you some data in that regard in an upcoming slide. If one chooses dialysis, then one needs to choose to create a vascular access or place a peritoneal dialysis catheter, to manage the metabolic complications, and to manage nutrition. Now, there's a very high mortality amongst the elderly who start dialysis. If you look at those over the age of 85 who start dialysis, by 6 months, only about 40% of those patients are alive. And even amongst those in the age of 75 to 84, there's a very high mortality rate at 6 months. Similarly, if you look at the number of comorbid conditions, those who have a number of comorbidities are going to have a very poor outcome compared to those who have fewer comorbidities. And it is for this reason that we're starting to think more and more about conservative management, symptom management in the elderly and those who have a significant number of comorbid conditions. So let's talk a little bit more specifically about hemodialysis. The essential components of the hemodialysis procedure include a dialyzer, the dialysate solution, and access to the circulation. Hemodialysis is a two-step process: diffusion and convection and ultrafiltration. In diffusion, solutes move down their concentration gradient from areas of high concentration to areas of low concentration. And fluid is removed by applying a transmembrane pressure gradient that drives fluid removal across that membrane. You get some clearance of solutes by convection when you apply this transmembrane pressure gradient across the dialyzer. The most commonly used dialyzers in the United States are hollow fiber dialyzers. This is a schematic of such a dialyzer. Blood moves in through this compartment and exits through this compartment. A dialysate solution moves in through this direction and flows countercurrent against the flow of blood and exits here. Blood flows through these fibers and dialysate around the outside and allows for diffusion to remove solutes. The dialysate is composed of a number of electrolytes. Sodium, potassium concentration may vary from 0 to 4 typically. The calcium concentration in milliequivalents per liter is 2.5 to 3.5, and the buffer is provided by bicarbonate. Importantly, there must be a vascular access. The preferred vascular access type is the AV fistula. It requires fewer interventions needed to maintain patency compared to the AV graft and has few infectious complications. The least desirable form of vascular access is a catheter, pictured here. Catheters may be tunnel or non-tunnel, and they're the least desirable because of their infectious risk. Once the patient is started on hemodialysis, the patient is referred to an outpatient dialysis center, usually the one closest to his or her home. And the patients are dialyzed in chairs or recliners in the outpatient setting. This is important for primary care doctors to know because some patients who are very frail may not be able to sit for 3 or 4 hours in a recliner. And so those are contribute to some of the problems for some of our elderly frail patients in terms of their being able to undergo the rigors of hemodialysis 3 times a week. Infection is the second leading cause of death in end-stage renal disease patients. Catheters are the vascular access type that is most associated with infections. Catheter-related bacteremia may be due to gram-positive or gram-negative organisms. And importantly, the nasal carriage of Staph aureus is a risk factor, so eliminating the carriage of Staph aureus may help to reduce the rate of vascular access infections. In terms of treating catheter-associated bacteremia, removal of the catheter and treatment with systemic antibiotics is the gold standard. Other approaches include catheter exchange with guide wires, with a guide wire plus systemic antibiotics, or systemic antibiotics plus an antibiotic lock. These approaches vary from center to center, and so you may see differing approaches depending upon the standards of care in your home institution. So our first knowledge check question: the preferred vascular access for hemodialysis in a 26-year-old man with end-stage renal disease due to glomerulonephritis is an AV graft, a tunnel catheter, an AV fistula, or a non-tunnel catheter. Great, thank you. And I can see that most of you answered chose the correct answer, which is an AV fistula. An AV fistula is most suited for this patient because he is young and he is going to need dialysis for a long time. Graft and a tunnel catheter, or a non-tunnel catheter, are not the ideal options for this patient. So let's move on to talk about peritoneal dialysis. The physiology of PD is very simple. The peritoneal membrane may serve as a diffusive surface for solutes to move from areas of high concentration to low concentration. An osmotic gradient from fluid removal or ultrafiltration is provided by glucose. And again, there's a dialysate solution. These solutions come in bags that may be 2, 2.5, or 3 liters. For automated PD, these are larger bags of 6 liters, and they contain electrolytes just as with hemodialysis, except they have no potassium. The buffer is lactate rather than bicarbonate, and they come in varying concentrations of glucose, which provide the osmotic gradient. This is a schematic diagram that illustrates how the peritoneal membrane may serve as a diffusive surface in which solutes may move from the blood to the dialysate compartment by diffusion. In this schematic, you can see that there's a bag of dialysis solution that is attached to the PD catheter. It goes into the peritoneal membrane, and after a period of about 4 to 6 hours after diffusion has taken place, along with ultrafiltration, then the patient may drain this bag of effluent or spent dialysate solution, and then repeat the process for the next exchange. There are two major types of PD. CAPD is continuous ambulatory peritoneal dialysis, in which the patient does manual exchanges, or continuous cycling peritoneal dialysis, in which the patient uses an automated cycler with a long daytime dwell. As we talked about earlier, PD is underutilized in the United States. Only about 8% of all dialysis patients in the United States use PD. However, when pre-dialysis modality education is provided, more patients tend to choose PD. PD patients also tend to report a greater quality of life and greater satisfaction with their therapy than do hemodialysis patients. Some of the barriers to utilization of PD include patient factors. Patients lack knowledge about it. They may be afraid. They may have poor social supports. They may have technical problems like limited manual dexterity that may limit their ability to do dialysis by the PD route. And finally, our patient population is aging, and older patients may be less likely to choose any form of home therapy. But there are also physician factors. Many nephrologists have not been adequately trained in PD and are less likely to recommend PD since they are not comfortable with it. And that's due to inadequate exposure and or training. Peritonitis is probably the most feared complication of PD. It remains the leading cause of patient transfer to hemodialysis. The signs and symptoms include fever, abdominal pain, abdominal tenderness or rebound tenderness, cloudy effluent, nausea or vomiting. The diagnosis is made by measuring the effluent cell count. A cell count greater than 100 with a predominance of polys is suggestive. And then sometimes the diagnosis may be suggested by the effluent gram stain. And the gold standard that guides therapy is the effluent culture. In terms of treating peritonitis, we typically treat it by administering intraperitoneal antibiotics for bacterial peritonitis. Vancomycin and ceftazidime are often used. The catheter needs to be removed, however, if the infection does not clear promptly. Fungal peritonitis requires prompt removal of the catheter along with systemic antifungals. We remove the catheter because it is very difficult to eradicate fungal peritonitis. We try to prevent peritonitis by eradicating the nasal carriage of Staph aureus prior to placement of a peritoneal dialysis catheter, and by having the patient apply a topical antibiotic daily to the exit site. These two antibiotics that we use are mupirocin and gentamicin, both of which have been shown to reduce rates of peritonitis and exit site infections. So for our next knowledge check question, which of the following is the leading cause of modality change from peritoneal dialysis to hemodialysis? Is it an exit site infection, membrane failure, peritonitis, or encapsulating peritoneal sclerosis? Please vote. Great, thank you. And I can see that most of you chose the correct answer. All of these, exit site infection, membrane failure, peritonitis, and encapsulating peritoneal sclerosis may lead to modality change from PD to HD. However, peritonitis is far and away the leading cause. So the last few minutes, we'll talk a little bit about kidney transplantation. Kidney transplantation is the optimal form of renal replacement. However, it is limited by the availability of organs. Organs may come from living related donors, living unrelated donors, or deceased donors. And there is such a thing as an extended criteria donor. This may include a donor who has had hepatitis C, for example. The medical evaluation of the transplant recipient is done by a multidisciplinary team that includes a surgeon, a nephrologist, a social worker, a pharmacist, and a psychiatrist. They're going to be paying particular attention to cardiovascular disease, malignancies, and infections, things like HIV, hepatitis B, hepatitis C, syphilis, CMV, and EBV. And the reason is that one wants to pick up these particular diseases so that they're known about prior to transplanting a patient, because without treating them appropriately, the patient may have an adverse outcome. These are some of the drugs that are used for immunosuppression for kidney transplantation. Steroids remain the backbone in many programs, and you know the typical side effects of steroids, so I won't go into these in detail. Azathioprine or mycophenolate are used in many programs, and then finally the calcineurin inhibitor is also commonly used. The side effects of glucocorticoids, azathioprine importantly inhibits purine biosynthesis and has a major interaction with allopurinol that is important for primary care physicians to know about. The major side effects of mycophenolate include diarrhea. They have a selective effect on lymphocyte replication. And finally, the calcineurin inhibitors have specific types of side effects. These include for cyclosporin, gingival hyperplasia, hypertension, and hirsutism, and for tacrolimus, diabetes, hypertension, and neurotoxicity. Some of the newer drugs include sirolimus, which is an mTOR inhibitor, which causes bone marrow suppression and hyperlipidemia. Monoclonal antibodies are used in many programs. These include drugs like basilistamab, sorry, I have trouble pronouncing that word, and it blocks the activated T cells expressing IL-2 receptors. And finally, many programs also use polyclonal antibodies such as ATGAM and thymoglobulin, which non-specifically block T cells. It's important to know that certain drugs may alter cyclosporin metabolism. The calcium channel blockers, some of the azoles, and macrolide antibiotics, as well as grapefruit juice, may increase levels of cyclosporin. Many of the anticonvulsants will decrease levels of cyclosporin. When patients have difficulty buying their medications, we would sometimes take advantage of this and use diltiazem or verapamil to raise the level of cyclosporin because of the patient's inability to adequately afford the medication. We should talk about infectious complications post-transplant. In the first month, surgical wound infections, urinary tract infections, and catheter-related bacteremia are the most common infections. At 1 to 6 months, CMV, EBV, pneumocystis, nocardia, and listeria or infections that we worry about. And so patients are typically given prophylaxis with drugs like trimethoprim sulfa, dapsone, and valganciclovir. And finally, after 6 months, as immunosuppression is reduced, the infectious complications tend to go down. But CMV disease, remember, may occur late, and it may be characterized by fever, leukopenia, malaise, and allograft dysfunction. Some of the non-infectious complications of kidney transplantation include cardiovascular disease, new onset of diabetes after transplantation, and malignancies such as skin cancer and cervical cancer. And finally, a rare complication is post-transplant lymphoproliferative disorder, which is a rare lymphoma that occurs in the setting of heavy immunosuppression and usually occurs in EBV negative recipients who received an EBV positive transplant. Now, in my last 3.5 minutes, I did want to talk about COVID-19, since this is something that we've learned something new about over the last few months. The first reported death from COVID-19 in the United States was in a dialysis patient, and that occurred at Northwest Kidney Centers, or the patient was a patient from Northwest Kidney Centers in Seattle. And their experience, which the rest of the country really modeled after, was that patients could be safely dialyzed in an outpatient dialysis clinic, even if they were COVID positive. Morbidity and mortality reports are conflicting. Some centers reported high mortality rates amongst dialysis populations, whereas others reported mortality rates that were comparable to the general population. This is a schematic of how Northwest Kidney Centers handle patient care. When patients would arrive for dialysis, they were screened for new cough, fever, sore throat, or new shortness of breath. If they didn't have any of these symptoms, they were proceed with standard dialysis. However, if they screened positive, then the patients were masked and put into a private room, if a private room was available, and they would implement all the transmission-based precautions for staff. If a private room was not available, then they would try to physically isolate the patient as far away as possible from other patients. In terms of kidney transplantation, this was reported in a letter to the New England Journal of Medicine from Montefiore in the Bronx. They identified 36 kidney transplant recipients who were COVID-19 between March 16th and April 1st. 72% of the patients were male, 39% were Black, and 42% were Hispanic. 69% had diabetes. Their presenting symptoms included fever and diarrhea. And in terms of their outcomes, you can see that 78% were admitted to the hospital, whereas 22% were monitored at home. 39% required mechanical ventilation, and 21% received renal replacement therapy. At a median follow-up of 21 days, 28% of the patients had died. So you can see, at least in this report from Montefiore, the outcomes in transplant patients were not great. So for our final knowledge check question, pneumocystis infection occurred most commonly in kidney transplant recipients during which time period? The first month post-transplant, 1 to 6 months post-transplant, 6 to 12 months post-transplant, or 5 to 10 years post-transplant? Okay. So pneumocystis infection typically occurs most commonly in the 1 to 6 month period post-transplant. So in summary, renal replacement options for the patient with advanced CKD include transplantation, hemodialysis, and peritoneal dialysis. Conservative or non-dialytic treatment may be appropriate for some patients with advanced chronic kidney disease. The preparation for renal replacement should include the timely placement of a vascular access or PD catheter. The AV fistula is the preferred vascular access for hemodialysis. Nasal carriage of Staph aureus is a risk factor for infectious complications in both hemodialysis and peritoneal dialysis. Peritonitis is the leading cause of transfer from hemodialysis to peritoneal dialysis. Kidney transplantation is the optimal form of renal replacement, but limited by organ availability. Infections, cardiovascular disease, diabetes, and malignancies are complications of transplantation for which patients should be monitored. Dialysis patients with COVID-19 may be cared for with precautions in outpatient dialysis facilities. And finally, kidney transplant recipients with COVID-19 are at high risk of mortality. So my time is up. We had a couple of questions, but I will ask Dr. Singh if he wants me to stop here or go through these questions.
Now you're live.
Hi, thank you, Kevin. That was great. If you can see the questions, that'd be great. If you want to go through them, or I can ask them. I can ask you questions, whatever you prefer. Yeah.
So we have the questions. So a 52-year-old man with end-stage renal disease secondary to diabetes is maintained on an immunosuppressive regimen of cyclosporin, mycophenolate mofetil, and prednisone. He develops post-transplant hypertension. Which of the following medications may affect cyclosporin levels? Is it losartan, enalapril, amlodipine, or hydrochlorothiazide? So please vote. Great, thank you. So 93% of you got the correct answer. Amlodipine, which is a calcium channel blocker, may affect cyclosporin levels, as will other calcium channel blockers, including diltiazem and verapamil. Losartan, enalapril, and hydrochlorothiazide do not affect cyclosporin levels. So let's see if I can. Okay, great. So the next question is, a 23-year-old woman with lupus nephritis has progressed to stage 4 chronic kidney disease despite aggressive treatment with cytotoxic agents. A recent kidney biopsy has shown advanced fibrosis, and her BMI is 30 kilograms per meter square. All the following are true with respect to renal replacement options, except A, she should be educated regarding hemodialysis, peritoneal dialysis, and transplantation. B, she should be encouraged to lose weight prior to renal transplantation. C, her obesity excludes her as a candidate for peritoneal dialysis. And D, she should be referred to a vascular surgeon for immediate creation of an AV fistula. Please vote. Okay, great. Thank you. So most of you got the correct answer, which is C, her obesity excludes her as a candidate for peritoneal dialysis. Obesity in and of itself is not a contraindication to peritoneal dialysis. We're able to dialyze effectively many obese patients who with PD. So let's go through these. A, she should be educated regarding hemodialysis, peritoneal dialysis, and transplantation. That is definitely true. All patients should be educated regarding all the modes of renal replacement. She should be encouraged to lose weight prior to renal transplantation. That is also true. Many transplant centers will not list patients for transplantations if their BMI is above a certain cutoff, and patients who are obese are at greater risk for developing new onset of diabetes after transplantation. So she should be encouraged to lose weight prior to renal transplantation. And C, she should be referred to a vascular surgeon for immediate creation of an AV fistula. She should be referred to a vascular surgeon for immediate creation of an AV fistula if she chooses to do hemodialysis after adequate education about all the renal replacement options. Okay, so we went through all of those options, so I can skip that. These are some references. And I thank you for your attention, and I look forward to joining you in the next section for questions and answers.